Okay.
Good
Thanks,
morning,
Chris.
everyone.
It's all yours.
So I'm Chris Wakeman. So I wear a number of hats, but I'm a colorectal surgeon and is my main job, my day job. But I also work for the New Zealand Familiar GI Cancer Service. So we deal with Lynch Syndrome and Lynch Syndrome families for the New Zealand Familiar GI Cancer Service. And as a surgeon, I obviously deal with cancers as well as need be. So just a bit of a brief run through, then we can answer some questions. So bowel cancer, which is a malignant growth of the bowel. 90% of 95% of polyp cancers start from polyps. And if we leave polyps and leave them for a long time, they may turn into cancer, but not all polyps will turn into cancer, is the flip side. There's a sequence where it takes time to change from normal skin to an adenoma or a polyp into a cancer. So that takes time, and everyone's polyp to cancer sequence may be different depending on what genes they've got and what abnormalities. So that might be rapid or it might be fast. So it might be a turtle or tortoise versus a hare, and we're never quite sure when we first get a snapshot of cancer. So signs about bowel cancer, so change in bowel habit. If you're a once-a-day person, all of a sudden it's all over the show, something been going on. Blood actually in the motion, becoming anemic, abdominal pain, unexplained weight loss. All these could be symptoms. They're obviously a little bit, they're not specific, it's not, but they raise concern, especially if you have a background of Lynch syndrome and you have these symptoms, you definitely need investigation. Average risk, this is non-Lynch patients. So in New Zealand, we have increased rates compared to the rest of the world, but if you're under 55, it's low risk. We are seeing increasing numbers of under 55s, but still overall risk is low, but that risk has increased. By the time you get to 75, you would have had a 1 in 18 chance as a male or 1 in 23 as a female. So not inconsiderable, and bowel cancer does make up, as far as deaths of patients for cancer, is the second most highest in New Zealand. The good thing about bowel cancer is it is preventable with screening. If we catch it early, we can cure it. And some people ask me, why do you want to be a colorectal surgeon? And that's one of the things why I like colorectal is I can help people. I can actually cure people if we treat them early enough. Where some of the other cancers, unfortunately, do some cool operating, but you don't actually help the patients. So we can actually do some good. So if we catch things early, we screen patients, we are proactive with their symptoms and move on, then hopefully we can stop cancers. So family history is really important, personal history and age, the sort of things. And you can't change some things, you can't change your genes, but we can, as long as we are aware of them and we act on any signs and symptoms in early investigation and keep screening up. So most people have not got a family history, so they're what we call sporadic. Genetic factors contribute about 25%. And then of those who've actually got a hereditary condition, we're down to about 5 to 10%, most common being Lynch syndrome. So we look at a pie chart, we can see the red is the sporadic, so that's just the bad luck ones basically. Then we have in the green familial, so there is a family history of bowel cancer, but it's not certain, not necessarily genetic, because there's other contributing factors, because obviously you live in the same house, you drink the same water, you probably got the same lifestyle as far as exercise, probably eat the same food, so there are some familial components, so you live in the same environment, obviously, so some farming environments. Then we get into these are the actual hereditary ones. So HMPC or Lynch syndrome is the big one we do see, but there are a lot more as well. And they're rare, and sometimes, especially in a small country of only 5 million people, we don't have too many families of those to manage. So hereditary cancers, we have non-polyposis, so they're the Lynchy ones on this side, and when they have the polyposis, so the adenomatous, so FAP or MAP or serrated polyposis, and some of the rare ones. So Lynch, which we're meant to be talking about today, is mainly a non-polyposis. Doesn't mean it doesn't evolve from polyps, but it's not you don't have hundreds and hundreds of polyps through your colon. So Lynch syndrome. So we'll just flip through this one. So first described by Scott Warthian. It's quite an interesting story. He was in America, and his seamstress actually said to him that she was going to die of either a gynecological or colorectal cancer. And he said, what? What are you talking about? What do you know? And he started looking at their family history, being arrogant doctor as we all are, didn't really believe her for a start. And he went, wow, there is something in this family. It's very weird. And so he did the first sort of family tree of a Lynch syndrome. Henry Lynch in the 60s sort of took that work and then expanded it, looked at more families, tracked it down. In the 60s, we didn't have the gene, but we could see that these families, there was something happening because generation after generation got cancer. He called it hereditary non-polyposis colorectal cancer. And that's because this is a colon of an FAP patient. So familial adenomatous polyps, you can see these are the polyps. There are hundreds of them throughout a colon. They'll have these by the time they're 25. So it's different to Lynch. Wow. By the 90s, we started to find the gene mutations. So these are the four main ones. So we've got MLH1, which is on chromosome 3, MSH2 on chromosome 2, MSH6, chromosome 2, PMS2 on chromosome 7. So they're all slightly different, but they have a mismatch repair. And in simple terms, this is a spell checker. Our DNA turns over constantly. So in the lining of your colon, you're shedding cells and growing new cells, and the DNA is used to make those cells. And if there's a mistake, your DNA checker should correct it so you don't get an abnormality. But if you have Lynch syndrome, you don't have your spell checker is incorrect, and it can't correct those mistakes. And so you get mistakes in the DNA, which lead to firstly polyps and then to cancers. Mm-hmm. Even though I don't really like the HMPPC term because it sort of implies that it's not to do with polyps, but Lynch syndrome, still the actual change will occur in a polyp. But and these are sort of stepwise as you get those mutations, which the spell checker is not correct, and you get mutations in all the different genes, and then you get the cancer. So Lynch syndrome is what we call autosomal dominant. So that's if you remember back to school biology, it's the simple Mendelian biology where they did with the sweet peas, Mendelian did. So if you have Lynch syndrome, you only need one gene out of the two genes to give it to you. And so you got a 50-50 chance of passing it on to your relative. And we detect it by looking for either microsatellite instability or most commonly, and it's now compulsory, so it should be done, all tumours in the bowel get immunohistochemistry done. And so that's the first thing we find normally is there might be a suspicious family, someone turns up with bowel cancer, we do the immunohistochemistry on the tumour, and that identifies that this is a Lynch-like tumour for a start. And these are funny brown stains, which we use to detect it. I don't think we need to go into too much detail, but this is what immunohistochemistry, and when I sit in a pathology meeting with my pathologist, he's telling me about what the tumour I removed. He shows me the pink slides, and then he shows me the brown slides.
So, sorry, Chris, did you say that all tumours are now checked for these Lynch-like variations?
Yes, they should. All bowel cancer tumours and malignant polyps, so there's a cancer focus in a polyp, they should all have immunohistochemistry done.
Oh, cool. That's good to know. Thank you.
That's right. Historical ones won't. So sometimes we will, in the familial bowel cancer registry, go back and say there was one sample from 10 years ago which didn't have immunohistochemistry. We can get those as long as the slides still exist. Christchurch lost a lot of material in the earthquake, but as long as there's pathology still around, we can retest and relook at families as well.
Oh, wow. That's really cool. Thank you.
So, as I said, each of these mutations is slightly different. They're all cause Lynch syndrome, but there's different ways. So these are more the classical forms. And so if you have this form, you're more likely to get bowel cancer. So we talk about penetrance. So some genetic conditions have 100% penetrance, and FAP is basically 100%. So if you have FAP, you will develop polyps, and you will, if we don't operate, get cancer.
Wow.
Lynch syndrome, it's different, and so these, especially these ones, are more attenuated. So you may get skip generations. And I think someone was asked a question about skip generations, because the penetrance is not 100%. Your mother, just say it was coming from your mother's line, your mother may not have ever developed a cancer, or just say she passed away because of a heart attack at 60 or 50, she may not have had time to develop a cancer as well. And so you might get a skip generation where there's nothing in the generation above you, but your grandparents had, and your great-grandparents all had Lynch-like tumours. So especially the attenuated ones with different penetrance, or funny things like wars where people died young before they could develop them. The classical form, though, is probably getting close, not 100%, but it's getting closer. FAP, as I showed you that picture, that they don't have hundreds of polyps. It's variable. You may only have 1 or 2 polyps, and you can still get Lynch syndrome cancers in the crypts, so deep in the gullies in the cells, and so it may not 100% from polyps, but most of them are. When we look at the families, you'll see multiple cancers in individuals. So some granny might have had 2 bowel cancers over 10 or 15 years. Usually earlier onset than the sporadic cancers, so younger, and they tend to be right-sided bowel cancers rather than left-sided. And then we have what we call extracolonic cancers as well. So colorectal, CRC, is the most common, then endometrial cancer, then ovarian, and then we get down to the very rare but associated bowel Lynch tumours, but they only make up a very small percentage of Lynch tumours. So bowel and endometrial are the most common, then ovarian. Talked about the risk varies for each mutation. Young tends to be right-sided. When I say proximal, it's right-sided. And synchronous and retacrous means, synchronous means that it's not uncommon to have 2 tumours at the same time. So you have that first colonoscopy, if you're, because of change in bowel habits, saying they find 2 tumours. Metacronous means that you have 1 operation, and within 18 months you get a second tumour. So within close association.
Interesting.
Varies with age. So those ones I gave you before, a lifetime risk. So you can see there is a difference. Each population in the world has slightly different risk factors. If we look at extracolonic, so uterine, so classical, you're getting up to 50%. So if I'm seeing a patient with a bowel cancer, an MLH1, and they're, say, 45 and finished having their family, I might have a chat with them about whether they'd consider a hysterectomy. Getting their ovaries out, you can see, yes, there may be an advantage, but then you've got the disadvantage of going into premature menopause and those risks. So that's a bit more debate about prophylactic oophorectomy, ovaries removal. But especially this one, you could argue it might be nice to get the uterus out potentially. If you're 25 and not had children, then probably I wouldn't be trying to bring that up and leave that for later. EPCAMs are one of the new mutations which lead to Lynch as well. We're still learning a bit about it. We have some families which have higher risk than population risk for some of these things in New Zealand. So what happens, how do we diagnose Lynch syndrome? So normally we look at the family tree, and there's something called Amsterdam criteria. So we get a family tree like this. So when I'm working for me, a GI Cancer Registry Service, we get referred to family. We can see, Sally over here, and then her mother, Carol, also had bowel cancer, and then the grandfather, George. So we have more than 3 generations. We don't have ages on this family tree, but young, and we've got bowel cancers. So we'd be suspicious. This looks like a suspicious family to us. If we take Sally's bowel cancer out. Just say Sally's our referral patient and she's the new cancer. So I take her bowel cancer out, I do the immunochemistry and that's abnormal, and then I send her off to get the ultimate diagnosis. We send her off for genetic testing, which then proves that it is a genetic disorder leading to Lynch. I'll go through some of that. So that then allows us to genetically test, say, Stephen next, because if Stephen's negative for the genetic testing, then he doesn't have Lynch syndrome, so the rest of his family, James and Susan, don't need testing. The other one I'd want to genetically test would be George and Alice, because their father, George Jr., or George II, he looks like he's positive as well. So that genetic testing then allows us to prophylactically test those in the family who need surveillance. Terminology is really confusing and we don't help you. So Lynch syndrome is when the genetic testing is positive. If the immunohistochemistry is abnormal and you've got the family history like that one I just showed you, but we can't find a genetic result, we call you presumed Lynch. We're still suspicious, but we just can't prove it. And the problem with presumed Lynch is we can't genetic test the rest of the family to exclude those, so we have to be presumed Lynch syndrome families end up more of the family needs to be colonoscoped and surveillance. Family cancer syndrome X is similar but not quite the same. We don't really understand. So there'll be immunohistochemistry will be normal, but they have that family tree which is suspicious. So it's a little bit of grey area, and we have to be aggressive with our colonoscopies if we're not sure. So genetic testing is really useful. We can find a positive test and we can test and we know who we should be managing. So once we've got a genetic test, then we work out we're going to start surveying them. So depending on the mutation, the classical one's yearly colonoscopy, the attenuated, so less aggressive forms of Lynch, we might move to 2 yearly. And colonoscopy surveillance, if you've got a genetic disorder, we will start about 18 to 20, depending. Endometrial cancer, there's no real good test for this. You can do a Papel, you can do ultrasounds, but they're not perfect. And that's why some people might choose, if they've finished their family, to have a prophylactic hysterectomy. Urological, some places in the world do yearly urine, looking for blood cells. Again, it's a little bit hit and miss. Gastric cancer is one of the associated, so stomach cancer. Again, there is some association, but it doesn't run in the families. And gastric cancer is a very environmental cancer. You look at worldwide, Asia, particularly Korea and Japan, have high rates of gastric cancer. And if you're a Lynch syndrome family, you have higher rates still. But that doesn't seem to come across to New Zealand. So if you have gastric cancer in your family, then we do offer surveillance. If there's no gastric cancer at all, then we wouldn't necessarily offer surveillance for stuff. You just get colonoscopic, not upper GI endoscopies. We've talked about some of these. So treatment, surgical treatment. So we don't offer prophylactic surgery for Lynch syndrome. So if you've got a genetic disorder, we don't say, we'll get your colon out by the time you're 35 or 30 or anything like that, because it's not 100% chance that you'll get bowel cancer. So we actively screen you, keep an eye on you, and if you develop a cancer, then we'll discuss what operation to do. And traditionally, we've taken a little bit more, so subtotal colectomy. So we've taken, I said, most tumours are on the right side, so we might take right side underneath the ribs towards the left-hand side, but not take all your bowel out, because obviously losing all your bowel has side effects. That's sort of what we traditionally offer, rather than going where if you have FAP, we want to get all your colon out as much as possible, because it's a prophylactic procedure. We're treating the tumour and we can survey it. You may not get another cancer.
I've just got a quick question here,
Yeah.
Chris, about
Everyone's welcome to interrupt.
yeah, sorry, about
That's all right.
health and life insurance. If you've got Lynch syndrome in your family, should you take it out before your children are genetically tested? So taking out health insurance.
I would,
Before
if you can get away with it,
Yeah.
yes, I would. They may still, if they ask about your genetic history, they may exclude it, and they shouldn't really be allowed to exclude it. That's not, shouldn't be about. And so if I was, yes, if I had about to get a genetic test, I think you'd be better to get your health insurance in early rather than wait till you had a genetic test. Definitely.
Lovely, thanks for that.
Especially with the current state of the public health sector at the moment.
Yeah, true that.
We talked about this already, sorry. We'll whiz through some of these so you can ask questions. The big thing in Lynch syndrome in the last 15 years has been aspirin. And aspirin really does decrease your risk of bowel cancer and endometrial cancer. So there's been these studies called the CAP studies, and we're on to CAP 3, which has not been released yet. And so the CAP studies look at aspirin versus some other things to try and prevent cancer. And they really have shown that it does delay your age to bowel cancer, now endometrial cancer. We don't know the dose. So 600 milligrams is quite a high dose. And so we can see from other studies with bowel cancer that a low dose of aspirin does decrease your risk of bowel cancer. So we currently offer what's called the heart dose, so 100 milligrams once a day is what we recommend. But there's this new study called the CAP 3, which hopefully will be out in the next year or two, which will be able to give us some information about the correct dosage. So I think that's a big changer. And that's also why we don't offer prophylactic surgery, because if you take aspirin, you can decrease your rates of developing cancer so considerably. So I think I've got some more slides after this, but in summary, colorectal cancer is common in New Zealand. Lynch syndrome is autosomal dominant, caused by these mutation. Active surveillance is important and can stop you and decrease your incidence. And if the other good thing about surveillance is we're trying to capture your cancer early so it hasn't spread. So New Zealand Family, just a quick run over who New Zealand Family GI Cancer Service are. So Ministry of Health funded, we're multidisciplinary, so I'm a colorectal surgeon in Christchurch. I've also got a gastroenterologist, and I've got 2 what we call family history assessors, which tend to be nurses, so they're the ones who contact you first. We have all offices in Auckland, Wellington, Christchurch. Teresa Chump, she's my offside, who's the gastroenterologist. So we want to see patients who have a family history of bowel cancer, multiple cancers, and definitely they've got a genetic disorder. And we help organise, and so we will nag. So if you've got Lynch syndrome, we will nag your public hospital to make sure that you're getting your surveillance colonoscopies on time. And we can see when if you're overdue, and I'll start writing letters to them, and my FHAs will be writing letters this week, advocate on behalf of you. We can also help organise the genetic testing for your family and other family members, and we also give some advice to the rest of the family. So we actively look after FAP Lynch and the other Lynch-related ones. So we'll manage the surveillance guidelines. For these other conditions, we'll give some advice early on and then let the hospitals manage it. So we talked about that. So we actively manage, so these numbers are actually a little bit behind. So families, we've got 689 families. This is about 5 years ago. I haven't given you the updated ones, being lazy, sorry. But we've got all these families which we actively manage. And there's a consent process. So if you don't want to be managed, then you don't have to manage, or if you don't want Auntie Jim to know, Uncle Jim to know that you've got Lynch, with your consent, we can tell them or not, vice versa. The other thing with any autosomal condition is pre-implantation genetics. So this is a needle extracting DNA out of an embryo. So it's called pre-implantation genetic diagnosis. So that needle going in, taking a few cells out, detecting whether that embryo has Lynch syndrome, and then that you can then make the decision with genetic counselling, genetic advice, whether that embryo gets put back in. So involves in a fertility cycle, but the government will pay for you to undergo, if you wish, you don't have to do it, but if you want to have your embryo screened for Lynch syndrome, you know you've got Lynch in your family, then that's a possibility as well. We can help set that up for you as well. There are limitations for what the government provides, but it is available. Obviously, and lots of ethical and legal aspects, and it's complex, consent. Who do you tell if someone doesn't want to tell their children they've got Lynch syndrome, but they've got Lynch syndrome in the family? There's lots of issues. Also, ethical issues about what age to test children. There's no benefit in Lynch syndrome in testing children too young. All it does is create angst amongst the family, because we're not going to start colonoscopic surveillance until they're at least 18, if not 20. And so there's no benefit in stressing everyone out, age 10 or 12, when the child can't understand the implications. So generally we try and put it off. There are some families who do get tested early because the family just wants to know, but there's a whole genetic counselling process to that. And I think I have finished my slides now.
Oh, I know where those carvings are. Those are Lake Taupo, hey?
They are, correct. I've lived in the South Island, but I grew up
all
in
the
the
time. Oh, they're so cool. Thank you for that. Just another quick question. So is that 100 milligrams of aspirin daily recommended if you have Lynch syndrome at the moment?
Correct.
So even if you've been diagnosed with it now, you can start taking that?
Yes, I would advise taking that. And we should have sent letters to all our Lynch syndrome patients to advise it from Familial GI Cancer Registry Service point of view. They should have received a letter at some point to them and their GPs advising that.
Oh, cool. Awesome. And also another comment that the familial service was brilliant at making sure someone got their annual colonoscopies. So,
good.
Yay.
Good to hear.
It's awesome.
Sometimes we feel like we're banging our head against the wall. I'm writing multiple letters to certain naughty hospitals. It's slow.
Well, apparently you guys are amazing at doing that and making sure people are followed up.
So Emma says, I wondered, we don't know about the different mutations, whether aspirin is useful for the more attenuated forms. But I mean, if you can take aspirin, if you don't have ulcers or you don't have a risk for taking aspirin, then I think it's worthwhile taking aspirin. I think the benefit from the evidence looks good. Even non-Lynch, there's a little bit of effect for aspirin and bowel cancer. It's not perfect, but it's definitely there. I'm being cynical, I take aspirin because I think, being a colorectal surgeon, I'm bound to die of colorectal cancer because it's going to happen to me.
Being surrounded by it all the time. And then I think somebody else was just about getting their kids tested and knowing that it's actually quite a stressful process, knowing when to actually start that. So,
yeah, as I say, we generally advise not doing it too early because the poor child can't understand the implications, and unfortunately, surgery sometimes is complication, and it's really quite stressful. You've, as a surgeon, potentially harmed, say, the father. He's had complications and he's got Lynch syndrome, and you're looking at the younger son going, you're going to need the same operation potentially. And so, yeah, it can be very stressful putting that stress on the children that they're genetically tested positive and they may need a major operation.
Yeah. They'll follow up with their GP.
Yeah, it's always good to talk to your GP if you're worried about the aspirin, but low dose is usually pretty good. But I mean, aspirin, like all drugs, like everything, has complications. So any concern, see your GP.
Yeah, particularly if somebody has a bleeding disorder or anything like that, is it worthwhile them still looking into the aspirin as a prophylactic?
Yeah, you have to be careful with bleeding disorders. So, definitely hemophiliacs and things like that, I wouldn't recommend taking it. It is a pros and cons, but if you've not got a bleeding disorder or if you had strokes, then you may not want to take it. But and even taking it for the first 10 years buys you a big window. And so the original CAP study just took it for 10 years and stopped it. And so we're not sure, do you need to take it for 30 years or is 10, 15 years enough to push it out?
Yeah, cool. Yeah. 18 sounds like a good sort of a general age, I think.
Yeah, well, there's sort of hopefully 18-year-olds mature enough to understand the implications of genetic testing.
Yeah, amazing. Cool. Has anyone else got any questions or any comments or anything? There's a little chat function, which is where some of these questions are coming from. If anyone has anything else, I know I've actually learned quite a bit about Lynch. I didn't realize that there was quite so many mutations that actually went with it, and it's nice to know that the different ones actually can be treated slightly differently and have different outcomes. So, been good learning.